Pleasure to, to me to introduce Victor Valcour. Victor is the director of the Atlantic Fellows for Brain Equity and Brain Health Training Program at the University of California, San Francisco, where he's also a professor of geriatric medicine in the Department of Neurology. His work aims to improve brain health worldwide by training a new generation of experts to meet community needs. With expertise of geriatric medicine, dementia, international research, he offers unique opportunities for Atlantic Fellows to understand the connections between aging and cognitive disorders from a truly global perspective, and to appreciate the inequities of brain health rooted in economic and social conditions. Dr. Valcour research focus on the impact of HIV in the brain, as well as examining the determinant of Alzheimer's disease and frontotemporal dementia. He have active research protocol in Asia, Africa, and both North and South America. As a personal note, I would like to mention that probably many of you know, or at least have been here about the GBHI, right? So the GBHI is doing an amazing, incredible impact worldwide, and especially, I would say, in the Global South. And nothing of this couldn't be possible without Victor. Victor has been managed to coordinate efforts across all the levels, from high levels in decision-making process, envisioning truly innovative things like creating capacity building grants. That is something that almost doesn't exist, and convincing the Alzheimer Association to invest in that for the future of regions that really needs capacity building for doing research. But he also is doing an amazing work with fellows, teaching them how to write grants, helping them to write grants, reviewing and co-writing grants with people across the globe, mentoring fellows, and it's, I don't know how Victor can manage the time. So for me, it's an honor working with him, and I have the pleasure of learning from him. And I think that the other important aspect that I want to mention is that Victor is really able to understand the challenges and the conditions that happen in completely different scenarios, completely different socioeconomical contexts. And this is a very, very atypical skill, and it's crucial for developing international collaborations. So for me, it will be a pleasure here, Victor, but especially because I want to learn more about your work in HIV, Victor, that we don't have much time to talk about that. So thank you so much.
That's very kind, and I don't believe anything that Augustine said, but I'm happy to be here, and thank you very much for that kind introduction. I imagine everyone can hear me okay?
Perfect.
Yeah, okay. So when I was asked to speak to this group, I had just given a talk to doctors that provide HIV care in the United States. And it's very timely here in the United States because new medicines are becoming available for the treatment of Alzheimer's disease here. And although quite controversial in how effective they are really creating a dialogue around disease-modifying agents for neurodegenerative syndromes. That's made a lot of people who care for individuals with HIV uncomfortable, because we really don't have a way to distinguish the cognitive impairment that's fairly common among people living with HIV, particularly elders living with HIV, from that of neurodegenerative syndromes. And as these disease-modifying agents became available, and many groups are beginning to beef up their ability to diagnose early so they can get people into either trials or therapies, even though, as I've suggested, these are quite controversial still. I think we will have more and more therapies available. And so this group of HIV providers asked me to put together this talk. So I hope it's reasonably contextual. I know there are too many slides for me to go through in 45 minutes, so we won't get through all of them, but I hope it will make you think a little bit about the challenges that we go through, at least here. So I'll start with a gentleman that I cared for myself. He was 75 years old. He was right-handed, and he had 16 years of education. He came to see me because he was having new memory problems. And he says, my brother died of Alzheimer's disease and had exactly the same symptoms. He was about my age. He had decline in memory. It started 5 years ago, but he still maintained his functional independence. He has very few comorbid diseases, some blood pressure issues. His lipids are a bit high. And regarding his HIV, this is a man who's been living with infection for nearly 40 years. Not uncommon for me in the people I care for in our clinics at the Memory and Aging Center. His immune status was never terrible. He never had that very low CD4 cell count immune status. And as a consequence, he's never had an opportunistic infection. He was very lucky to live many years without treatment and not develop these diseases. And currently, he's on a very good therapy that includes an integrase-based regimen. His counts are nice and high, CD4 cell count. We cannot detect virus in his plasma. So his HIV is under impeccable care, and he has these symptoms. When I did a Montreal cognitive assessment test, this is a screening test, he scores 24 out of 30. Typically, this would put somebody in a mild cognitive impairment stage. And as you look at the things he can't do, you can see his cube copy is terrible. He can't connect the dots for our trails. So he's having quite a bit of executive dysfunction. And when asked to draw a clock with the hands at 10 minutes after 11, you can see his clock is almost it just doesn't make any sense what he's trying to do here. But what caught my eye is the fact that he did not know what a rhinoceros was. Now, this is not a common animal here, so you could say there are a lot of folks that might not know what a rhinoceros is, but healthy people with 16 years of education usually know that, even healthy people living with HIV, because one of the few things people tend to retain is the ability for confrontational naming language in HIV, and that bothered me a little bit. At the same time, you can see at the bottom that he was able to remember 4 out of 5 words that he learned, so his memory was not quite as bad. When we did imaging on him, we identified really no abnormality. In fact, he didn't have a lot of atrophy despite living with HIV for 40 years. So the question that I was posed was, does this man have Alzheimer's disease like his brother did? So he's got a first-degree relative with Alzheimer's disease. Or is this a more typical HIV-related impairment, which is very common in elders? Maybe as much as 30% of people living with HIV in old age will have a cognitive syndrome. I also, wondered myself, can I increase my confidence on what he has through some kind of biomarker, either imaging or CSF? And now we have blood-based biomarkers coming out. What's the likelihood that they could help in this situation? But there are larger, more unanswered questions in this scenario. Is Alzheimer's disease more frequent in older people living with HIV? You will find people that say, of course it is. And then you look at the data and say, we don't know. So this is a controversy. Will people living with HIV be more at risk for other kinds of dementia? For example, dementia with Lewy bodies, vascular dementia. Will Alzheimer's disease progress differently, or will it present differently in people who are living with HIV? These are, I'll tell you the punchline, all unanswered questions. We don't have enough information to understand how to care for people living with HIV. Let me give you a brief history of what we know about how the virus impacts the brain in people living with HIV. There are lots of criteria that have passed through, and I'm going to skip this slide because I imagine most of you are not clinicians, but the criteria have changed over years for how we define HIV impairment. For this slide, I just want to say what I've already told you. Probably about a third of people live with a cognitive syndrome, particularly in old age, even though they have suppressed plasma viremia on good treatment and are doing well otherwise, but they're living with a mild cognitive impairment. Usually when they have a cognitive impairment, it affects a couple of cognitive domains, not just memory. Often it's attentional deficits that look like a memory deficit, or sometimes they'll have executive abnormalities. The symptoms that people often tell me is that they may read a paragraph and not remember what they read. Sometimes they may have watched parts of a movie and then asked to rewind it because they missed what was happening. They kind of zoned out. They also have difficulty multitasking. So if they focus on doing one thing, they're fine. But if they're trying to answer the phone, run the front desk, and get a fax, things start getting confusing for them. It's quite common to have information processing speed deficits in people living with HIV. When I talk to patients, I tell them that this is like having thicker oil in your car. It doesn't run quite as quickly as it should, whereas thinner oil would run better. And for those of you who understand imaging, we see this on diffusion tensor imaging. We see abnormalities on diffusion tensor imaging that suggest that the axons aren't firing as quickly as they should. So it makes sense that multitasking is harder, information processing is a little bit slower. The course does not typically progress in HIV. Now, that's been a lifesaver. I've been following people for over 10 years that remain in the same level of kind of a fluctuating encephalopathy. So they don't really progress like Alzheimer's disease, but they just kind of remain up here. So those of you who are really thinking about what I'm saying, you automatically know now how to distinguish HIV from Alzheimer's disease. Watch them for 5 years. If they get worse, it's almost certainly Alzheimer's disease. If they stay the same and fluctuate a little bit, it's probably not Alzheimer's disease. That's a very unsatisfying answer to give a patient, to come back in 5 years and I'll tell you what you had. So we do have room to go, but you can see that there are differences in progression at any rate. As I pointed out, HIV has a very kind of typical phenotype. When we think of neurodegenerative disorders, the phrase that's quite common is selective vulnerability, right? So with Alzheimer's disease, for whatever reason, there appears to be a selective vulnerability to the medial temporal lobes. And so in a classic presentation, you'll see an amnestic presentation, memory problems, although we know there are other presentations that occur as well. In frontal temporal dementia, there's a predilection to the frontal and temporal lobes. As a consequence, you find behavioral changes, apathy, lack of motivation, a lot of behavior changes, as well as sometimes a presentation that's quite language-centric. However, with HIV, there's much more of a ubiquitous presentation because the virus is probably affecting all parts of the brain, perhaps the deep gray structures more, so you might see more information processing speed, psychomotor speed abnormalities, but in fact, we see all types of problems that affect behavior, affect motor, and affect cognition. If you allow an individual to go for their life without treatment and they have a progressive HIV disorder, it's quite common they will look like a Parkinson's disease, a person living with Parkinson's disease by late disease. So there's a clear motor component to this. And we are often humbled by people presenting with behavioral abnormalities. A classic case here at UCSF, a profound apathy that was treated as depression for a long time before somebody realized this person had advanced HIV disease. And I also saw a case, I was presented a case in one of my trips to Ireland of somebody presenting with mania. So these can occur. What's more is if you live with HIV for a long time, probably because of the inflammation that is caused, you will have cerebrovascular disease. It's common. We see it with great frequency. In this autopsy series of people who died in the first decade of this century, and this was a time when we didn't have great treatments for HIV, 50% of people that died in their mid-40s had moderate to severe atherosclerosis as autopsy. So we know that small vessel ischemic disease is common. Here is what it looks like for those of you who read brain images. These are two different patients that I cared for. In the top is a distribution of these very bright white parts that are more classic. In the bottom, a less classic presentation of discrete lesions. Both of these occur in people living with HIV, and in fact, both occur in people that are healthy, but we don't see the discrete lesions as much on the bottom. This burden of white matter damage links to their cognitive performance and also links to the number of cardiovascular risk factors they have. So we think that this is a combination of both HIV and cardiovascular risk factors. But what's more important in HIV is that despite having suppressed plasma virus, the best treatment you can have, we can still measure inflammation in the brains of individuals. In this first study, the top bar, a ligand called TPSO, which is a microglial activation marker, was increased in a group of people living with HIV without symptoms, cognitively normal, tested normal, but they had more microglial activation. And when they look carefully at the performance on executive functioning, the amount of microglial activation correlated to poorer performance and executive function, even though it was in the normal range. So this is likely having an impact. And on the bottom point, you can see that if we measure blood-based biomarkers inflammation, particularly those linked to monocytes, we can clearly find a link to cognitive performance in people living with HIV. This is a paper that we published that showed that if you have elevated monocyte markers such as monocyte chemotactis protein, MCP, and neopterin, which is excreted by monocytes, you have abnormalities in diffusion tensor imaging. And these diffusion tensor imaging abnormalities link to cognitive performance. So in this case, we were able to not only link a blood-based biomarker of inflammation to cognitive performance, but we were able to show that it seems to be mediated through abnormalities in diffusion tensor imaging, so axonal damage. And then also among older people living with HIV, we see progressive atrophy over 3 years, even among people who are suppressed. All of the patients that I see in my studies, all the participants are suppressed with good treatment. And you can see, for example, the cerebellum, an annual decrease in size of 0.42% compared to 0.02% in age-matched healthy controls, something that's quite concerning. And when people ask me if people are at higher risk for Alzheimer's disease when they're living with HIV, it's hard for me to say no because of this vulnerability that is probably affecting resilience in response to a pathology of Alzheimer's disease. So I don't think it's necessarily linked to having more pathology, but if you do have pathology with a decreased brain reserve, you're more likely to present clinically with the disease. Okay, key points that I pointed out about HIV and its disease. The frequency of brain injury is less clear, but probably about 30% of older people living with HIV. We really don't know about younger people who may have been treated in earlier life, probably less. Certainly the work we're doing in Bangkok, Thailand right now for people that are put on therapy within the first month of infection, we're finding 10 years out that they have no cognitive impairment. So this may be an impact of having lived with virus for a long time or exposed to those less favorable antiretrovirals. But we really don't know among younger people. And also in older people, vascular injury seems to be important. Let me give a review now, and this is probably something all of you know, perhaps even better than me, of some of the age-associated neurodegenerative syndromes as they may pertain to people living with HIV. First of all, you may know there are various stages of disease, from those that do not impair function, where people can be having disease but cognitively unimpaired, to a mild disease, to a mild dementia, and then to moderate and severe. So we have these levels of progression. The term dementia does not specify an underlying disease, but a syndrome in which you have functional decline due to some neurodegenerative process. And among those neurodegenerative processes around the world, the one that is most common is Alzheimer's disease, but we also must think about things like vascular disease, Lewy body dementia, and frontal temporal dementia. Some, particularly elders, will have mixed pathology. When you look at the brains of individuals with these diseases, and I've listed 3 here, Alzheimer's, frontal temporal dementia, and dementia with Lewy bodies, there are clear protein depositions that correlate with these diseases. As most of you probably know, A beta and tau are common among people living with Alzheimer's disease, in fact, necessary to have both. Whereas with FTD, you may have various pathologies and various proteins that are found in the brain, from tau to FUS to TDP43, and commonly with dementia with Lewy bodies, alpha-synuclein. And some of you are probably very aware that it's not that clear. In fact, you can have quite a bit of amyloid, which was seen in this case of Illyria from Colombia, but not have manifestations of disease in the absence of tau. So Alzheimer's disease, for Alzheimer's disease, amyloid is necessary, but not sufficient to have a clinical presentation. Now, in the United States, 6.5 million people are living with Alzheimer's disease, and the progression goes up with age as it does around the world. Interestingly, in the United States, the projected increase in the rates of disease will be much higher in places with poorer social determinants of health, particularly in the American South. And that's very applicable to places around the world where we expect higher increases in low and middle income countries and Latin American countries, not only because the populations are aging, but because the social determinants of health and cardiometabolic factors are higher. I'm going to skip that because it's very US centric. So underrepresented minorities in the United States are also they're underrepresented in research. For example, high risk among African Americans is probably driven by social determinants of health in the United States, not by race. Nearly 2/3 of Alzheimer's disease occurs in women, and this may be affected by life expectancy biases and other social determinants of health, although there's possibly as well other disease mechanisms leading to that. Many of you may have seen these risk factors from the Lancet Commission identifying modifiable risk factors across the world. This is in high-income countries where up to 35% of dementia can be modified. But if you look at low middle-income countries, and particularly Latin America, it's estimated that about 56% can be modifiable. And I think most of you probably know that. And I mentioned before, this is not only because the populations are aging rapidly, but also because of social demographic factors and cardiometabolic factors related to that. So AD is characterized by alteration of cerebrospinal fluid proteins as well, with decreased A beta 142, increased tau, and increased phospho-tau in this classic design of the progression of disease that you can see on the right. That's very popular in the Alzheimer's disease literature. As well, you can have neurologic correlates with MRI, and symptomatic changes may occur even later after a lot of these changes begin to occur. What is really making people nervous in the United States right now is we now have, in fact, last month, the first blood-based biomarker has been available for testing Alzheimer's disease. I'm told as well there's now a biomarker that you can have measured outside of the clinical care that may not have the performance characteristics that's necessary. But even though these are the earliest studies, the earliest tests that are available and may not be optimized, we've passed a critical point in the work that's happening in the United States. As more blood-based biomarkers come out and we understand their performance better, it's changing the landscape entirely. So what does that mean if you're in a clinic caring for somebody living with HIV who comes with cognitive impairment? Is it a knee-jerk reaction to order a blood-based biomarker? This is something we don't know. That is a very dangerous move, I would think, as a clinician. I think using blood-based biomarkers solely to make diagnosis among people with a broad differential diagnosis is going to cause lots of problems. And this is why I'm being asked to speak on this topic quite a bit, even though I don't have a lot of the answers. The blood-based biomarkers are not great yet, right? I mean, if you look here on the left, the overlap in positive and negatives is substantial. And so although we can use in studies and say they discriminate pretty well, it doesn't come anywhere close to what's happening with some of the PET markers that we have. So we have a long way to go to move these blood-based biomarkers. And these are the ones that are likely to become available clinically here in the United States. But even those that some of you are thinking of using in research studies, it's critical to understand that the phenotype is critical to have, and their use in diagnostics is going to be a tricky interpretation in some cases. I'm going to skip this. It's really telling the same story that are saying more about these blood-based biomarkers. So with Alzheimer's disease particularly, symptomatic treatment is with a cholinesterase inhibitor. It doesn't work that well. It increases acetylcholine in the brain. And you can also use NMDA receptor antagonists. We call it memantine here. This one works even worse. But as I said, disease-modifying treatments are now available. In the United States, I believe now we have 2 that are approved, and 1 is FDA approved and getting Medicare approval. So this is changing the landscape. Unfortunately, these studies were based on very specific enrollment criteria. And so it's whether these are going to work in a more broad group of people with Alzheimer's disease, particularly those that may have comorbidity. These are things that are going to be determined in the next 5 years. I'm going to skip this as well, because what I really want to get to is the intersection of HIV and Alzheimer's disease. So I've given you a little bit of an overview of my understanding of how the brain is affected by HIV, particularly among elders, which is where my research has been for the past 20 years. And I've given you a little bit of the landscape of neurodegenerative syndromes, but we're focusing a bit on Alzheimer's disease now. This picture of me back in 2002, 20 years ago, with an Aloha shirt on when I was working in Honolulu, was kind of a pivotal moment in my life. I wasn't really intending to study HIV. I was I wrote a grant that unusual got funded, a very large grant, and I found myself studying elders living with HIV in the state of Hawaii in the United States. This woman was very brave. She was in my office for a research study the day that the Honolulu Advertiser, which is the big newspaper, came to my office to do a story on aging with HIV in Honolulu. And they said, do you have anyone who might be willing to be in the picture with you? And I said, no, there's a woman here for my studies, but I wouldn't ask her. And they said, well, ask her. So I said, you know, they want a picture. Are you at all interested in being in the front page of the Honolulu Advertiser? And she said, of course I'm interested. I'm a woman of color, and people don't think that I'm at risk for HIV. I'm a heterosexual woman. And she said, I got HIV. I need everyone to know that they're at risk. So very brave woman, but a long history for me. So whether the course, features, or timing, onset of HIV, of Alzheimer's disease and HIV is simply not known. There's insufficient evidence to know if other forms of dementia, like Lewy body dementia, will be more frequent. We don't know. But we do know a bit about the pathology, particularly among people that didn't have treatment for HIV. And what we know is there's evidence of increased amyloid, particularly soluble amyloid. In early studies where they took what they called brain balls of people that died, they would take pieces of brain, they'd homogenize it and look for soluble amyloid, substantial soluble amyloid. There also has been TDP-43 found in people living with HIV in frontal temporal lobes, published as far back as 2008. And alpha-synuclein is also seen at an increased rate in people living with HIV without disease. And as I mentioned before, the data I pointed out for progressive brain atrophy among elders, white matter damage, and persistent inflammation would make you think that these individuals are at increased risk for the clinical manifestations of a neuropathologic disease should they have the neuropathology, although I'm not absolutely certain they're at higher risk for the neuropathology, but I do think they're at higher risk for the clinical manifestation. This is a study that I pointed out about alpha beta plaques in the frontal lobes. The longer you have HIV, the more likely you are to have these amyloid, soluble amyloid markers in the frontal temporal lobes. This is one study that used an amyloid compound in people living with HIV who are asymptomatic. And what they found among these younger people, 47, that there was no evidence of neuritic plaques among these individuals. The challenge with using amyloid imaging to distinguish Alzheimer's disease from people living with HIV with a cognitive disorder is that if you apply amyloid imaging to somebody in their 70s, about 20% of healthy people who don't have disease will have a positive PET. So if the PET's negative, you can exclude Alzheimer's disease. However, if it's positive, you're still kind of not clear on what you have. Our personal experience is that the rate of amyloid positivity in people in their 70s is a little less than the population that a healthy control population. We're publishing that data now, but we also had a very select group of people that are treated, suppressed, and had a cognitive syndrome. So among people with treatment, suppressed virus, cognitive syndrome, the rate of amyloid positivity is about half of what you would expect for controls. And we'll be trying to publish that soon. And amyloid imaging is hard to get paid for. Here at our center, it costs $4,000 to do one image. There's also a disconnect between CSF amyloid and PIB among people living with HIV. And this is important to note. If you do a lumbar puncture and measure CSF amyloid and tau, about a third of the time, either the amyloid or the tau will be perturbed in healthy people without Alzheimer's disease, but living with HIV. So it makes it difficult to use these CSF biomarkers. If the CSF biomarkers are normal, you're reassured. And sometimes they're abnormal in both tau and amyloid in a way you can't ignore. We're following one individual now. I've been following him for 5 years. He has a very clear CSF amyloid and tau profile for Alzheimer's disease. He hasn't yet presented with Alzheimer's disease. He's got an impairment, but it's a stable HIV impairment. And I just think it's a matter of time before we start seeing the decline of Alzheimer's disease in him. But these are not perfect tests, is my point. Here's another older study showing the exact same thing. The ADC on the left means AIDS dementia complex. And you don't need to look at all the details here. Just trust me that there's perturbation of these markers in CSF among people living with HIV that makes it difficult to use them in the setting of Alzheimer's disease. Here showing the same thing in the pink, you can see people with AIDS dementia complex with some overlap with Alzheimer's disease, right? With a very broad range that includes that of controls, but also those with Alzheimer's disease. As a consequence, it's really hard to use this marker in people living with HIV. Here's a study early on that showed increased tau in the hippocampus of people living with HIV. This was a small study out of Edinburgh. People who died and were on therapy, but we don't know if they were suppressed, and they showed elevated amounts of tau. So there is some evidence, at least, that HIV may perturb tau as well. So only 5% of Alzheimer's disease have known genetic predetermination. So in other cases, the etiology is unclear. Among older people, multiple unproven hypotheses include environmental exposures, inflammation, and other infections. So there are existing theories already about infections such as CMV and herpes simplex virus contributing to the risk for Alzheimer's disease. Is it possible that HIV as well? Most data presented in the setting of HIV were captured really before we had effective therapies. So we're unsure if what I'm showing you in all these autopsy studies will hold out among people who get treated early, which is now the norm. These days, if you're identified to be living with HIV, you're put on treatment immediately, regardless of your immune status, which is very different than the people that I see in clinic who are 70, 80, and sometimes 90 years old, living with HIV for the past 40 years. So let's get back to my case. 75-year-old right-handed man, 16 years of education. So I thought about this quite a bit, and I thought about all the data I've been presenting to you about HIV versus Alzheimer's disease. This is a review we published in 2017. And the key here is that there's a lot of overlap between the two diseases. Even ApoE4, a known risk factor for Alzheimer's disease, there are several published articles showing that ApoE4 is an increased risk for HIV-related impairment as well. If you think about his profile on his cognitive test, there's a lot of overlap between the HIV-associated neurocognitive disorder that we call HAND and Alzheimer's disease. So you really can't rely on it. Clinicians will say, well, one is a cortical process and one is a subcortical process. So you would expect the neuropsychological profile to be different. You can't rely on that. I have followed people with a pure amnestic syndrome who are amyloid negative, and they go on for many years without progression. You can use a little bit about whether they're encoding or having a retrieval problem. And I would add that the problem there is people living with HIV are very error prone. So they make a lot of errors, making that difficult to interpret. We have some hope that machine learning can solve this for us. If we put in a machine learning algorithm, people living with HIV with a cognitive syndrome side by side with age-matched people living with Alzheimer's disease, the computer can determine with 100% accuracy the difference between the two groups. You need my plug. So we have some hope that there's going to be a capacity to distinguish it using machine learning approaches. So what do we do in this case report? Well, this is more for the HIV clinicians. Do you modify their antiretrovirals for greater CNS penetration? I didn't cover that, but the answer is no for those of you that are clinicians. There's no evidence that modifying antiretrovirals will improve people living with a cognitive disorder. Should you start cholinesterase inhibitors, assuming he may have Alzheimer's disease? It would be empiric therapy and possibly wrong, but it's something to consider. Should you watch and wait? Because if they have longitudinal decline over 3 years, they're likely to have Alzheimer's disease, or is it and not HIV? It's reasonable, but would you yourself want to wait? Where we're getting to at this point is these blood-based biomarkers and or CSF biomarkers or PET amyloid biomarkers can help quite a bit, although they're not perfect. And that's where I would suggest we move next. Okay, so this person I saw was lucky to enroll in a research study. It turned out he was amyloid PET negative, and my work was done. He had an HIV-related cognitive impairment with a negative amyloid. It's not possible. Well, it's exceedingly unlikely that he has Alzheimer's disease. So, and as we followed this individual longitudinally, he had a mild fluctuating cognitive impairment that's often seen in HIV. He did not have progression. So we were lucky in this case to be able to clarify that a bit. I can stop here or go on. I think it may be best to stop here because the next part of what I'm going to talk about, it will be very clinical and based for clinicians in the HIV setting, going over what we can do to treat Alzheimer's disease, largely around cognitive stimulation, keeping people involved, limiting polypharmacy and so forth. But I'll ask the team what they would prefer. I can open it up to answer more questions or move on. Any thoughts from the group?
I just think, Victor, that this is a mixed group of more basic research, but also there is a set of clinicians. So maybe that part will be also of interest for them. I don't know.
Okay, let me go through them quickly. What do we do with these individuals that come into our clinic? Well, critical that people continue to be adherent to their medications. Patients will often tell me, I hear that the medications for HIV can cause cognitive impairment. The truth is there are some data suggesting that to be true. The truth is as well that not being untreated is almost a death sentence for most people. There's no option. And it's probably improving their cognition substantially. So adherence with persistent plasma suppression is important. And if you have a patient that comes and says, I am suppressed, but I'm not taking the medicines the way I should, have a conversation with them. I have a patient that takes it 3 days a week, not the other 4. He says he's always suppressed. I ask him, do they draw your blood after the day 3 of being on the therapy? Because that's probably true. And you're probably blipping up in between, and that's a problem. Sometimes you can get changes in medications that help, particularly if they have motor syndromes. If you think carefully about the antiretrovirals, sometimes they have side effects that you can change. And I've had one success in that space where we removed a disequilibrium because of a medication, but the person still had a cognitive syndrome. Referral to a specialist if you're having challenges trying to distinguish these two. I didn't talk about CSF escape. It's a rare phenomenon where there's virus detectable in the CNS, and I can talk to people individually if they want to know more about it. And then, of course, treating polypharmacy, trying to limit medicines. It's not uncommon for my 80-year-olds to come in on 20 or more medications. We published a study maybe 10 years ago of about 80 people living with HIV, and cumulatively, they were on about 2,000 medications and supplements. So polypharmacy is quite common in people living with HIV. Think about modifiable risk factors and ensure that you're addressing hearing loss, blood pressure problems, obesity, smoking, and so forth. Train around compensatory measures. The one unique thing about the HIV syndrome is that you can use compensatory measures. If you try to help someone with Alzheimer's disease providing compensatory measures, they'll often forget that they were told to use compensatory measures. But among people living with HIV, they often come into me already doing this. They'll keep lists. They'll keep reminders on their phone. They'll use alerts in some way. And this is quite helpful. Also, limit multitasking. When it's helpful, when they're willing to, I ask my patients to disclose to their friends that they have a cognitive syndrome with HIV, and they may have challenges keeping up with conversations. You can imagine if your processing speed is slower and you're in a room with 2 or 3 people, they're all talking, maybe joking around, and you can't keep up with the conversation. You become socially isolated. So perhaps disclosing to say, I really enjoy the social engagement that I have, but I may need to do it one-on-one. Most of the time, my patients aren't willing to do that. Reassure them that they're on a trajectory that's not likely to progress in the way that they're used to when they hear the word dementia, and empower them that there are a lot of people that have these symptoms. They're not alone. We did a study where we used mindfulness-based stress reduction to try to improve concentration for people living with HIV. And what we learned is that when they had the mindfulness class, they were put in a class with 10 to 12 other people living with HIV with a cognitive syndrome. And although their concentration didn't improve at all, their quality of life improved quite a bit. And when we did qualitative studies to ask, why do you think that happened? The answer was, I learned that there were people worse than me, that I'm not alone. There's a lot of people, and it's not going to progress. So I think that's important information for people to hear. So my summary, impaired cognition remains an important and frequent challenge in the era of combination antiretroviral therapies. That's the CART at the end. Cognitive impairment affects about 1/3, maybe a half, but I think it's closer to 1/3 of people with viral suppression in older years. I don't think it's going to be anywhere near that for our 20, 30, and 40-year-olds if they get on therapy early, but we don't have good point estimates for that. Chronic inflammation underpins the chronic mild fluctuating encephalopathy that we see among elders, and cerebrovascular disease is common, particularly among elders living with HIV. Due to advancing age, we can't avoid the fact that our patients living with HIV will have increased risk for Alzheimer's disease. And distinguishing it from HIV-related impairment is simply an urgent issue that needs to be resolved. We need to have ways for our clinicians to be able to give some advice to patients around this challenging issue. Relying on neuropsychological testing patterns alone is going to be a challenge. It's helpful, but it's not perfect. And Alzheimer's disease biomarkers are not perfect as well, but they're likely to be helpful enough in the short term, particularly when in the right hands. Using blood-based biomarkers, home tests, or just going to your primary care test to use a blood-based marker to tell if you have Alzheimer's or not is going to be very scary for at least the near future. It's important to follow emerging reports related to Alzheimer's disease, particularly the likelihood of available blood-based tests, as they're going to change a lot in the next few years. The first test, I'm guessing, even though it was developed by my brother, I found out the other day, it just came on the market. It's coming out of Valcour in the United States. He runs that assay. The first test that comes out is likely to be the worst test, until you get those data points, and you really test it a lot. And we probably will find ourselves in 5 years using different blood-based tests. But this will take a lot of work. In people living with HIV, we have to establish whether the thresholds will be different. And quite honestly, in all locations around the world, we probably need to determine if those cut points are going to be different, because a number of cultural, environmental factors are likely to affect this. And as I said, disease-modifying agents for Alzheimer's, they're here. As we say to the geriatricians who fought this for the longest time, get used to it. They're here. You got to learn to live with it and work with it, and they're likely to get better and better. They certainly are proving an important scientific point that allows us to advance science. Their efficacy, I think we're going to find more than slightly mixed in a short time. Thank you so much for all of that. I will stop sharing my slides, and I'd be happy to take questions. I'm a little over, but not too much. I see a question from Felipe.
Yeah, thank you, Victor. That was super, super interesting, especially for a non-clinician like myself. And I want to ask you a non-clinician kind of more basic question here. Do you think there's will be any advantage to use or to compare or use animal models, humanized animal models, to basically understand the kind of the difference between AD and HAND that could help us later to find basically any specific biomarkers and to know a little bit more on what's going on in the brain in these two kind of overlapping kind of diseases?
Yeah, no, I do think that that's possible. Quite a few people are doing it. And particularly looking at some of the particles. I'm sure you've heard things like VPR and TAT. These are particles of HIV. They're probably amyloidogenic, and you could prove some of that more and more in animal models, with the caveat that animal models don't always link to clinical outcomes, but they do give you lots of hints in direction of where to go.
Okay. Thank you.
Maybe Andrea?
Hi. Thank you a lot for your talk. It was very, very interesting. But at the same time, as a clinician, it introduces more difficulty when we see patients with HIV. Indeed, and in our memory clinical, frequently we receive people from with either without or without treatment, and with memory complaint. I think most of the people we receive are almost people 50 or 60 years old. So generally we evaluate them, but sometimes we find nothing in neuropsychological evaluation. Sometimes we find a diagnosis of dementia, but your talk opened a new venue about the possibility of Alzheimer's disease and how this data has changed your practice. Or is too early to change the practice when you see someone with cognitive complaint without a treatment with AIDS.
Yeah, I think I understand your question, Andrea. When I first started studying aging with HIV, the first cohort I had was the HIV over 50 cohort. So I was only looking at people living over 50. I found that a little boring because people in their 50s, they usually have an HIV-related impairment, or they have comorbidities that are affecting their cognition. A lot of times, a lot of social issues, sometimes drug use that worries me, sometimes, inadequate treatment of HIV, a lot of things that can be addressed in kind of a different way. So when I moved to San Francisco, I said, enough with the people under 60, let's look at people over 60. They're the more interesting group. And then in my clinic, I'm seeing mostly people over 70 and 80 and 90. I think the thing they want more than anything is diagnostic clarity. And I often can't give it 100%, but I don't feel terrible at the end of the day that I'm not initiating new therapies. If they have a more rapid progression, or their cognitive syndrome is in the past 2 years, or they have unusual presentations for HIV, they're going to get a lumbar puncture from me, no matter what, because I want to make sure they don't have CSF virus. That's the escape phenomenon I'm sure you're familiar with. And I will do blood-based biomarkers. I'll do CSF biomarkers, I'm sorry. And doing the combination of those two, I can exclude the one treatable condition, which is escape, and I can get a hint towards Alzheimer's disease. If the hint gives me reassurance, I tell them, I don't think this is Alzheimer's disease. And you don't have any features to fit anything like Lewy body or frontal temporal dementia. So we'll watch, but I think you have an HIV-related impairment. If they're on the fence, I'm in a little bit of a pickle, and I tell them we don't know how to interpret this. And then I go more on my clinical feeling. And if they have, Alzheimer's markers that are clear, I usually tell them either that I think they have a contribution from Alzheimer's, or I think they're in a preclinical phase of Alzheimer's disease, and that they should get their affairs in order and be worried that they may have progression over the next 5 years. And I think that goes a long way to giving them some level of clarity about what is happening in their lives, even though I'm not offering a new drug or a new therapy. In terms of the new anti-amyloid therapies, I can't imagine a center is going to use these in people living with HIV in the short term. It's just not going to happen. It'll be an exclusion. So that's off the table, at least in the short term, as far as I'm concerned, in terms of treatment, because there won't be absolute clarity of the diagnosis. And at least in the short term, the centers, the reputable centers, the academic centers that are going to be using these are going to be very, very careful about the phenotype. Augustin?
Wonderful presentation, Victor. Thank you so much for your time to share your expertise with the Gero community. 2 questions. The first one, you already started to talk in the previous comment from Andrea. So I thought that for HIV, it would be prohibitive to have antibody, this kind of treatments, especially regarding, if you have small vessel disease, inflammation in general, or white matter hyperintensities, this should be a higher risk for areas, right? So it won't happen in the HIV, as I thought, but I would really like to know your clarification.
Yeah, I don't know if it's not going to happen. The people that are gearing up to give these anti-amyloid therapies are a lot of private centers that see a money opportunity here. I don't know how they're going to apply the criteria. I think it's like, I don't even think I would refer anyone here at UCSF because of the points you make. It's too early. The people that are going to be eligible are going to be people that are usually probably early life dementia with a very clear phenotype and a biomarker that are probably ApoE4 negative. That's probably who's going, because it's going to be really looking at people that are going to be the safest and most likely to have an impact. So I don't see how somebody living with HIV, with the things you point, atrophy, another disease, white matter disease, inflammation, I don't think it's going to be a group that they're going to be anxious to be treating.
Great, thank you. And the second question is, most of the evidence you presented is related to Alzheimer's disease, but given that the one hypothetical pathway for neurocognitive deficits is inflammation, we should think about many other neurodegenerative conditions, but there is no research about that, or it's less replication in the studies. Why is most of them related to AD?
Well, AD is the most common, but I pointed out TDP-43 is increased, alpha-synuclein is increased, at least in these early studies where they were looking. This is a group out of San Diego who looks quite a bit at, they have a brain bank down there. And so they've seen those. But I think, I don't know, I present mostly Alzheimer's because it's the most common and there's probably the most data on it. I don't think, I saw a person with really terrible delusions, persecutory, and at times, bugs coming through the walls, and just a terrible scenario of complete disturbance with visual auditory hallucination. He had a little Parkinson's disease, and I was worried. We did get autopsy. It was pure Alzheimer's disease, which makes me really wonder the degree to which HIV may change the phenotype of how people present in a way that I don't know yet, So I don't think I've ever seen a Lewy body. Oh, no, well, I might have seen one, but mostly I've seen, probably a couple dozen Alzheimer's disease cases in people living with HIV in older age, of which maybe 8 or so have been autopsy or biomarker proven. So I just haven't seen a lot of it. Maybe that's why, there's not as much available in the literature.
Thank you. Thank you so much.
There's a really interesting case that I saw, and then I'll stop talking, of somebody who presented with idiopathic Parkinson's disease. And I was certain it was due to his HIV, which was under control. It was not under control. And it was interesting. It was a rather rapid progression of Parkinson's disease. And with a cognitive syndrome, they came to me for the cognitive syndrome, but it's very clear that this person was developing a rapid Parkinson's disease. Unfortunately, he had stage 4 prostate cancer, and he decided to go into hospice and do nothing, didn't want to have anything done. But I was convinced that that was a Parkinson's disease induced due to untreated HIV. And there's one published case of an individual who was diagnosed with progressive supranuclear palsy and was later determined to have HIV. He treated the HIV and his PSP went away. So the HIV can clearly affect the basal ganglia in ways that, and the brainstem in ways that are can cause phenocopies of some of these diseases. So you're right. I think that we'll see that. Great. Nice seeing and meeting all of you. I hope this provided some interesting afternoon for you, and happy to take anything by email.
I think that Andrea wants to mention something, but I just want to say thank you so much, Victor, for your time. I know how busy is your agenda. We really appreciate your time. Andrea?
No, just another question. The ability of biomarker as sense of practice, because a lot of countries we don't have biomarker when we see this patient. And do you ask them Alzheimer biomarker, lumbar puncture?
In the clinic, we can get Alzheimer's biomarkers pretty easily. They're done now at the Mayo Clinic. We send them out. Blood-based biomarkers, I learned on Monday, you can now order them from this company called Valcour, but it's brand new. And from at least the comments I heard from our faculty, it's questionable their performance, which is the one my brother made. So we're gonna have a little family feud over blood-based biomarkers the next time we get together for Christmas. But yeah, so we can, Andrea, order them in our clinic now. Great. Thanks, everybody. Enjoy the rest of your day.
Thank you so much.
Thank you.
Thank you. Bye.
Thank you very much.